Good evening to all the aspirant. Good evening, sir.
Yeah,
Sir, shall we start?
good evening. Yeah, we shall start.
Okay. So the today's topic is acute coronary care, which is class 2. And the speaker that we have here is Dr. Sangshaptak Saha. He is an associate consultant in critical care medicine at Apollo Hospital, Kolkata. Thank you, sir.
Good evening, everybody. So today is the second class for the acute coronary care. Basically, I have done related to the acute coronary syndrome. We have discussed everything that was there to discuss in the last class, including the posterior wall and inferior wall AMIs and the ECGs. And there are also a small test at the end of the session, and I also shared the PDF of that, the PPT of that. So today, basically, we shall discuss about the pericarditis and the myocarditis. Not the whole of those things, but only the acute parts and those which are relevant to the ICU. We shall also be discussing a bit about the pericardial effusion, constitutive pericarditis, and in the end, we have a very special topic, brief 15 to 20 minutes talk. We shall get there as we reach there. Yeah, the last 15 to 20 minutes, at least for me, it was very interesting to prepare for that. So, okay, I think everybody should keep their mics. Yeah, mute. That will be better. So starting off with this myocarditis, this is basically the definition. So histologically, we have the Dallas criteria and the immunological and immunohistochemical criteria. So basically, because this is a part one, EDIC part one exam related class. So basically, they will ask about the Dallas criteria directly, or they will ask what is the basis of the classification of myocarditis, especially in the ICU. Then they will tell the immunological immunohistochemical criteria. So most of the things, most of the slides they have prepared, those are direct questions from previous EDIC questions. And it's I want to repeat that it is not a class only on myocarditis and pericarditis, because that is a large thing and that is not required for your EDIC part one. So epidemiology, the global incidence is something like 4 to 14, 15 people per lakh patients annually, with a mortality rate of 1 to 7%. But why we have included is because this is very favorite of them in the recent years. This myocarditis in SARS-CoV-2 infection versus COVID-19 vaccination. So myocarditis risk increases by a factor of 2 and 15 after vaccination and infection. Higher rates were with Moderna vaccines followed by the Pfizer vaccines. And strangely, males were more susceptible to myocarditis. Okay. So there is something called myocarditis, which is occurring after the COVID-19 vaccination and also after COVID-19 infection. So COVID-19 infection myocarditis survival rate is worse, whereas if it is following the vaccination, survival rate is more. So once again, the vaccine is causing the myocarditis, but the people are surviving more, and the mechanism is different. The mechanism is mostly this hypersensitivity reaction if it is post vaccination, and if it is this post myocarditis, if it is post infection, then it is mostly the endothelial injury and microthrombus. Both of these, this endothelial injury, microthrombus, and hypersensitivity reaction, both of these are previous MCQs. Hypersensitivity reaction is with the vaccine, it has a better survival rate. Okay, this is what you have to remember. So again, the classification, why do we need it for the exam? This is because the eosinophilic myocarditis, giant cell myocarditis, cardiac sarcoidosis, these are the three for which you need the corticosteroids. We use use corticosteroids in every case of myocarditis. Like the guidelines, these are the three where you have to use the corticosteroids. Obviously, the higher dose of corticosteroids, 2 milligram per kg body weight of IV methylprednisolone, followed by tapering off gradually over 10 to 14 days. And you can also use mycophenolate mofetil and other immunosuppressants as well. Whereas in the lymphatic myocarditis, this corticosteroid can be used, but it is optional to use. So it is not a grade 1 recommendation yet. Whereas in polymorphic myocarditis is basically post-infection and their corticosteroids should not be used. So no role of steroids here. Basically, they will ask about this eosinophilic. Giant cell is a very favorite of EDIC 1 and also cardiac sarcoidosis where you have to use the corticosteroids. Okay. So basically, they can give you a clinical case scenario where the patient has got some viral infections, usually HIV, hepatitis, mumps, influenza, or a bacterial infection like pneumococcus or psittacosis. It can be following candida or aspergillosis or following leptospirosis. In fact, we have a patient right now in our ICU who presented following a travel to a hilly area with AKI, acute liver injury, transaminitis, and thrombocytopenia. We sent a leptospirosis panel, but it came out to be negative. Then we again repeated it, and we are awaiting the result. But the patient has got all the features of leptospirosis along with the travel history. So we are suspecting that the patient may have got the leptospirosis, and the patient also has got reduced ejection fraction. He's a young patient. He's what I mean. He's in his 40s, 45, 46 years old. No prior history of cardiac disease, but his ejection fraction was around 40%. Unlikely that he was having ejection fraction of 40% before the disease. So it may be a case of leptospirosis induced myocarditis. Just a practical case scenario. So it is not something impractical. Okay, this myocarditis, inflammatory myocarditis, all of us see the ICU, and not only the septic shock related myocarditis because the pathophysiology of that is different. And of course, the Chagas disease is there, which is a common chronic, but Chaga, yeah, in European centers, Chagas can happen. It can be a question at least. It not does not happening native South American disease, and of course, the Southeast Asian countries, malaria mediated myocarditis is very common. So it's a wide range, but we have to remember that mostly it is viral. It can be bacterial, streptoneumo. It can be spirochetes, leptospira, or malaria. Candida and aspergillosis will not come as myocarditis in an EDIC Part 1 exam. And these are all the non-infectious causes. We just have to remember these vaccinations, snake bites, these infections, and sarcoidosis, thyrotoxicosis, collagen vascular disease, and maybe heavy metals, and of course alcohol toxicity, which is a separate question altogether. So how to because in EDIC 1 they can give you direct questions, but in many times they give you the clinical picture. So patient presents with the flu-like symptoms with some chest pain, and these are the ECG findings, and then you have to diagnose. So clinical features, physical examination, mostly the features of LV or RV dysfunction, depending on what is there. It can be tachycardia, it can be the gallops, it can be pericarditis, peripheral edema, ascites, pleural effusion, pericardial effusion, elevated JVP, hepatomegaly, and of course shock. Any of them can be the findings. So these are basically findings of left ventricular, right ventricular failure, depending upon which part of the heart is involved. So clinical presentation can be as a case of acute heart failure, dilated cardiomyopathy, or it can be a subclinical case. Now, this acute heart failure, we have to manage as a heart failure only. So we have to manage the preload. If it is a patient is in overload, we have to use diuretics or a renal replacement therapy with ultrafiltration removal. If the patient is underfilled, we have to give some fluid volume. We have to manage the afterload. We have to use the dobutamine or milidone to decrease the peripheral vascular resistance if it is increased. If not, we have to use the inotropes like vasopressin and noradrenaline. Noradrenaline is the drug of choice. So the usual acute heart failure management. And of course, there is also the option of using the ECMO and the LVADs. Remember, they last year or the year before that, I think they gave a question on EDIC 1. I'm talking about. They gave a question on myocarditis, and then it was a long stem. So patient presented like these disease features, there's ECG changes, he was in shock, all the infective cultures were ruled out, and the patient's ejection fraction was something 20-25%. He is not responding to anode probes, his BP is still low, 80/50, despite a non-adherent vasopressin, and triadobutamine also been given, his peripheral vascular resistance is still low. So what will you do next? Obviously, the answer was VA ECMO. So in an MCQ exam, it seems because you have the options in front of you, it's not that difficult. But you just remember that yes, VA ECMO is a part because it is nothing but an acute heart failure. That is why we are including this in the acute coronary care class, because although you do not include this acute coronary care in general, but I included this because you have two classes and there's nothing to discuss on acute coronary care and it is useless to discuss the same thing again and again. So we are discussing this right now. So you remember that acute heart failure may be with dilated cardiomyopathy, which underlying cause will be myocarditis, or there may be subclinical myocarditis. There can be transient increase in troponin or ECG abnormalities after an acute viral illness or vaccination. This vaccination I am repeating again and again. This is a very important MCQ topic for anyone. Okay. Differentials can be anything. It can be an IHD, ischemic heart disease, it can be a heart failure, it can be pulmonary edema, it can be dilated cardiomyopathy, it can be alcoholic cardiomyopathy, it can be sepsis. As I told that they will tell you that the septic markers are not there. So it can be anything. So differential they will not ask in EDIC one, obviously. But you have to differentiate it on the basis of the clinical scenario given. Because although they will not ask directly, but they will give something. What is your next step? Whether you will do an echocardiogram or whether you will send a sepsis profile. So that you have to pick it up from the step that is being given. Very important. So blood markers, as you have discussed, we obviously in a cardiac case we shall do the these basic cardiac biomarkers, that is the troponins and the NT-proBNP and the CPKMB, those things. But because this sepsis is a cause, I mean it's a DD, so we should also be doing this ESR, CRP, and the procal. The procal obviously will be negative in this case, but the ESR and CRP will be increased because it is inflammatory, right? And that is why CRP is not that good a marker in case of sepsis, but it is a good negative marker. But here CRP can be elevated up to 99% of cases. And of course, you have to work up for this hepatitis panel and the HIV and the leptospira and the malaria cultures, etc., etc. And in advanced centers, and of course, the patient has got financially able, then the serum cardiac antibodies and endomyocardial biopsy, and of course the MRI, cardiac MRI. This you need to do. We shall discuss on more on cardiac MRI and EMB in the next few slides. Okay. So another favorite topic for this EDIC part one. What are the ECG changes of this pericarditis or myocarditis? Pericarditis, there are typical ECG changes. In myocarditis, they are mostly non-specific STTF changes. It can present with simple atrial tachycardia or fibrillation, or it can present with a high-grade AV block. Okay. So you cannot really differentiate on the basis of ECG findings. The ECG will just tell you that something is going on with the heart. While in the echocardiography, ESC recommending standard TT. So they will ask whether TOE needs to be done or not as a baseline investigation. It is not a baseline investigation. You can do a TOE in the latter part. It is an advanced investigation. A TTE is enough. Just a minute. Sorry. So yes. So indications for endomyocardial biopsy for the EDIC part one, you don't have to remember all the cases, but if there is suspicion for this giant cell myocarditis, as I told previously, giant cell myocarditis is a very favorite topic for EDIC part one. If there is hemodynamically significant arrhythmias, if there is advanced heart failure, if there is a suspicion or diagnosis of systemic autoimmune diseases like SLE, polyarteritis nodosa, rheumatoid arthritis, mixed connective tissue disease, then you have to do. If there are acute symptoms of heart failure, refractory management, then you have to do. So, okay. So mostly giant cell myocarditis before using the steroids, acute heart failure, this refractory arrhythmias, And if there is systemic rheumatological disease, then you have to do the endomyocardial biopsy. It's easier to remember. Dallas criteria, only the name is important basically, rather than the whole criteria. Basically, they do biopsy, and depending on the biopsy findings, they classify. Okay, based upon the inflammatory infiltration, fibrosis. This much is enough. Don't have to remember the whole criteria. The name is good enough. So this is a nutshell of what we have discussed so far. So what is the clinical presentation? It can be an acute chest pain or a new onset or worsening dyspnea, trace or exercise. It can be palpitation or unexpected cardiogenic shock. What is the what is the diagnostic criteria? Diagnostic criteria basically Dallas criteria, but that is the biopsy based. Other than that, ECG or a Holter we can do. We can do a echocardiography, obviously. We can do this elevated. We can do these cardiac markers, TROP9, and we can do a this cardiac MRI, or you can do an echo or angio also. So clinically suspected myocarditis, we basically need a clinical presentation with the clinical features. We need the diagnostic criteria for different categories symptomatic patients. And importantly, the angiographically, there should be the detectable coronary artery disease should be absent. So an angio is required for diagnosis. Okay. Coronary artery stenosis should be, it should be less than 50%, obviously. Management is basically hemodynamically unstable patient. Management is just like a heart failure management in ICU patients. We have discussed that already. For hemodynamically stable patients, all again heart failure management with the diuretics, beta blockers, ACE inhibitors, and the spironolactone, and fluid management of fluid overload if there is any. Okay. So management is not that important because it will basically the heart failure management. It is just understanding that this is a case of myocarditis in exam. That is what is important, and remembering the Dallas criteria. So, is there any role of immunomodulatory therapy? Yes, high dose IV immunoglobulin, immunoadsorption. These are not proven. These are not proven, and these are not grade one recommendations either. But yes, you can use it. But they will mostly ask whether it is a grade one recommendation. Your answer will be no. This is again a management algorithm. Just to highlight the same thing again, you have to remember the symptoms, which are basically any symptoms related to cardiac cause, an ECG, an echocardiogram, and a troponin levels. If it is uncomplicated presentation, then we can admit, we can repeat an ECG, troponin levels, and perform a coronary angiography. As I told, it is required for ruling out any coronary artery disease. And if it is a complicated presentation, we basically have to do it like a acute heart failure and its complications like management. So to manage the arrhythmias and the fulminant myocarditis like features. If there is a persistent chest pain, then we can give some insights. The next question is when to use the steroids. As I told in the first slide, that is the most important question. Giant cell myocarditis, eosinophilic myocarditis, cardiac sarcoidosis, you have to use immunosuppression. Lymphocytic myocarditis is a case by case basis. Okay. And cardiac MRI can be considered in patients without mechanical cardio support if the EMB is not available locally or facility or low experience. So this is an obvious indication of cardiac MRI. If your diagnosis is suspicious or if the EMB is not available, then you can go for a cardiac MRI. So cardiac MRI is not recommended in every case. This again is a previous year's question. See these simple things they ask in EDIC 1. You need to ask the patient that he needs to avoid intense exercise for 3 to 6 months even after discharge. And the follow-up is 6 months echocardiogram or CMR. Both of them are previous EDIC 1 questions. Okay. I'm marking those things which you see, so you can take the screenshots if you feel like. It's not an issue. Okay, so we shall discuss fulminant myocarditis and then we shall come to the conclusion of the part 1, which is myocarditis. Next is pericarditis, and the last 15 minutes, as I told, will be something very, very interesting. So what is pulmonary myocarditis? Why it is important? It is important because it can kill the patient. That is the simplest answer why it is important. So the patient will present with circulatory compromise, maybe a right-sided heart failure, although left-sided heart failure can also occur. In a de novo acute heart failure, young patient, we have seen 3 to 4 patients in our ICU. All the patients were under 40 or 45 years of age with fulminant myocarditis, and I think 2 of them died. One of them she had to undergo tracheostomy, and the other patient, recovered in 7 to 8 days. And the tracheostomy patient also required a VA ECMO. So yeah, so very bad, prognosis of the disease. The VA ECMO patient actually survived. She was a young 23 years old female. She went to her college, and next day she had a fever, and after 2 days she was in shock. When she came, her BP was not recordable. She underwent a CPR cycle. She achieved ROSC. She went into a VA ECMO by our ECMO team. Within, I think, 30 minutes of her presentation, she was already being cannulation was, it had already started, and within 1 hour she was on a VA ECMO support. Basically, that's why she survived. Otherwise, though, she would have died. That's the bottom line of ECMO, right? ECMO saves people. There's no doubt about that. If you're working in an ECMO center, you will know. Otherwise, there's a lot of people who do not work in ECMO center in intensivists only, who are like, it's so costly and many less people survive. But yeah, if you're 23 years old female survives, who went into the disease the next day after going to normal college, then yeah, I believe it's worth it. Anyway, so the investigations will be the same investigations, no extra points. You just have to remember that if the patient is presenting with acute shock and young patient, maybe chest pain and those things after flu-like illness, suspect fulminant myocarditis. Because in the exam they'll not give you the fulminant myocarditis, they'll give you very closely related answers. Fulminant myocarditis, ACS, pericarditis, pericardial effusion, maybe something like those things. You have to rule those out. It will be very close. It will not be likely fulminant myocarditis and acute liver failure. Because obviously then the acute liver failure will not be the answer if they had not given something like jaundice or something. EDIC one, the options will be very close to one another. You have to rule it out clinically. Just read the question one time or 2 times, they will definitely hide some clue there. I mean, otherwise you will not get the answer, right? Okay, so let's go what they are telling. Management of the cardiogenic shock, avoid treatment of sinus tachycardia, avoid giving IV fluid for hypotension. So early inotropes. This is very, we mean early support for the heart. So early vasopressors also. If not working, go for a MCS early, mechanical cardiac support early. Use early invasive management to rule out epicardial coronary disease, endomyocardial biopsy if possible, and obviously hemodynamic and respiratory support, which is the inotropes and the medical and the MCS. Okay. So this is once again the diseases which carry bad prognosis, the 4 major myocardial subtypes which can be fulminant. It can be giant cell, acute necrotizing eosinophilic, immune checkpoint inhibitor myocarditis, and the fulminant lymphocytic myocarditis. So basically, these two, the giant cell and acute necrotizing, we are using the hydrocortisone, right? The steroids or the methylprednisolone. This immune checkpoint inhibitor myocarditis is associated with your SLE and this mixed connective tissue disease, polyarteritis nodosa, PAN, and also with severe sepsis. And is very difficult to treat. Mortality rate is very high because you don't have a specific disease, treatment, right? You only support the heart. Mortality is very high with immune checkpoint inhibitor myocarditis. It carries a very grave prognosis. So if you remember these 4 names: giant cell myocarditis, acute eosinophilic myocarditis, immune checkpoint, and fulminant lymphocytic myocarditis. This I think we have already discussed. The clinical feature most common is chest pain after 2 to 3 days after second mRNA vaccine. Due to the spike protein of this SARS-CoV-2 that occurs. I think now the fascination with COVID-19 is coming down, so maybe they will not ask. But last 2-3 years it was very common to be asked. That's why I've included in the slides today. Diagnosis treatment is exactly similar for myocarditis, so no need to go into details for that. So before going for pericarditis, I shall just check the chat box whether there is any questions or not, and then we shall just proceed. Okay. Okay. So there are only 6 candidates today. Anyway, that's fine. Okay. So no, nothing in the chat box as of now, and yeah. So I shall continue with the myocarditis. I'm sorry, the pericarditis. Where did it go? Yeah, pericardial disease. Pericardial syndromes, acute and recurrent pericarditis, pericardial effusion with a major hemodynamic compromise, cardiac tamponade, constrictive, and this. So mostly we shall discuss about the cardiac tamponade and a bit about constrictive pericarditis. But we shall start off with acute pericarditis just to get off with the acute management, because I think a couple of questions, not in the actual exam, but in the EDIC preparatory course and the EDIC related MCQ books, they have included some of those, insights and the call sheet, what the answers in those. So I'm just so that you guys get an idea. So pericarditis is the most common disease of the pericardium. And most of the many patients who present with pericardial effusion, they have got an underlying pericarditis. In hospital mortality is very low, because usually they get diagnosed and it's a chronic disease. And the pericardial effusion is because you almost always do an echo for every patient that present in ICU, or even in the ward for that matter. So pericardial effusion is very commonly diagnosed, and pericardial tamponade is hardly ever missed. That's why the in the hospital mortality is very low, because the other disease are chronic diseases. Only cardiac tamponade is the disease which can kill, isn't it? Pericardial effusion with cardiac tamponade. The others are chronic diseases, so they will not kill, which is unlike the myocarditis. Myocarditis actually kills. Pericarditis is it will not kill you usually, unless you are in that 1.1%. So I am from India. So the most common cause here is tuberculosis. In Africa, it is HIV. In European countries, along with HIV, it is SLE, rheumatoid arthritis. That is the all the rheumatological diseases: SLE, rheumatoid arthritis, polyarthritis nodosa, these things. Other than that, it can be uremia, uremic pericarditis, which is also an indication for renal replacement therapy. Another favorite question for EDIC 1, EDIC 2, and basically any clinical exam that you can think of. Neoplasm, post cardiac surgery, and after medicinal radiation. I am telling everything of this because all of these questions can come in the exam. Basically, they will tell you the scenario. Yes, this person had tuberculosis, and then in this pain and these things, and now yes, present in shock. So then you have to think that yes, it can be a case of pericardial effusion. Okay. So don't forget tuberculosis, don't forget HIV, don't forget the rheumatic diseases, and I always want to first five. One, two, three, fourth is uremia, and fifth is the neoplasms and post cardiac surgery. Clinical features, nothing different from any cardiac presentation. Chest pain, shortness of breath, maybe if there is pericardial effusion, ECG changes, and pericardial friction rub. ECG changes of pericarditis we shall discuss later on. Let's discuss it right now only. Yeah. So ECG changes of acute pericarditis. As you all know, there are two changes: PR depression and ST elevation. ST elevation is concave and it is present in almost all the leads, distinguishing it from acute myocardial infarction. So that is why pericarditis ECG comes in the exam, because you have to differentiate it. In the exam, usually they will give you the clue with this PR depression, and this ST elevation will be something like this, and it will be a pan lead, ST elevation, and it is a concave, right? It is a concave ST elevation. Yeah. But pericarditis, this is the stage 1. So only if the patient presents in acute phase, then you can see it. So this is stage 1. In stage 2, again the normalization starts, which is usually after the first week. Stage 3, T waves become inverted, which is the common pattern of T waves in chronic diseases. So that is after a month, usually after 3 weeks. And in stage 4, it is normal ECG. Less than 50% of patients undergo all 4 stages. So the MCQ will come based upon this only, stage 1. But you remember that there are 4 stages. So even if the patient comes with a TO inversion or with not that prominent STOF changes, even then it can be the disease if the patient is presented after a week or after a month, depending upon the duration of the illness. Okay. So what is pericardial rub? It is a high-pitched scratchy sound which is best heard at the left sternal border because it will be heard in relation to the heart. So how to differentiate pleural rub? It is just common sense, nothing else. Pleural rub obviously can be heard only during inspiration, expiration. It is heard over the lateral parts, that is the lungs, right? With increased pressure, intensity rub will increase because we are increasing the depth with the heart. But in a pericardial rub, it can be even heard without breathing, heard mostly on the, as we told, in the left sternal border, and intensity will not increase with increased pressure of the state. Investigation basically need to do an ECG, cardiography, all the cardiac troponins and the NT-proBNP, and you also have to do a chest X-ray and a cardiac MRI if possible. The cardiac MRI is the most sensitive, and it rule out the rheumatological diseases, HIV, tuberculosis, and the urea creatinine levels, and the neoplastic. If it's neoplastic, then the associated investigations for the cancer also. I have found at least 6 or 7 good pictures. I have included them all so that you do not miss it in the exam. I don't think you will miss it because anybody who works in ICU will know it anyway. So clear cut picture, and in an exam they will give a clear cut picture of pericardial effusion. They will not confuse you. So this is the margin of the heart, and this is the pericardial effusion, obviously. And this is the parasternal short axis view. This is obviously a pericardial uptake of gadolinium, which you do not see that much because you do not do these cardiac MRIs that much, right? So you see these deep white. This is where they have picked up the gadolinium because that is the site of the pericarditis, and the inflamed tissue has picked up more of the contrast. The gadolinium is the contrast. So that is the diagnosis there. Yeah. So for diagnosis, we need to do an ECG, an echo, into a chest X-ray, and you need to send this CK and troponins and NT-proBNPs. All are class 1 recommendations. So what is the management? Management is mostly supportive to treat the underlying disease. For the pericarditis in particular, treatment is NSAIDs, colchicine, and corticosteroids. NSAIDs, usually aspirin is used. Aspirin, the dose is 1 gram TDS, and the colchicine is 0.5 milligram OD or BD. What is the role for glucocorticoids? Glucocorticoids, the main role is when you cannot give for NSAIDs, you have specific indications like inflammatory disease, and start it at the lowest possible dose and then see what is the reaction. So always treat the fever, always treat the hemodynamics. Large pericardial effusion, obviously you need to drain. If there is an acute trauma, then yes, management of the trauma, use the help of CTPS or trauma surgeon. Start NSAIDs and then think about glucocorticoids. As I told, aspirin is 1 gram TDS. Ibuprofen, if you are using it, is 600 milligram TDS. And colchicine is 0.5 milligram OD or BD. Duration is 3 months. Duration is 2 weeks. So after AMI, pericarditis can happen. The sole purpose is because of this Dressler's syndrome, which is again because it is a named syndrome. So again, a favorite question for anyone. It is a rare phenomenon. It occurs a few months after AMI. It is a polyserositis. So there will be pleural effusion as well. Pleural effusion with pericardial effusion. Treatment is same: aspirin, colchicine, and the glucocorticoids. Just remember the name Dressler syndrome. It occurs after a week to a few months of AMI. But if it occurs within first 1 to 3 days, then it is not called Dressler syndrome. It is simply called early pericarditis. If there is a post-AMI pericarditis in the first 2 to 3 days, it is a marker of a larger infarct size. So it has got some prognostic value as well, right? As we already discussed, acute pericarditis or good prognosis. If there is an underlying systemic disease, then the prognosis of that disease can affect it. Coming to the cardiac tamponade. These I shall not discuss that much in detail because I think everybody knows this. Just the cardiac tamponade, the common causes will be, yeah, the common causes will be trauma, which is the most common thing asked in the exam. It can be following a cardiac surgery, neoplasm malignancy. It can be following tuberculosis or pericarditis. Uncommon causes, not that uncommon in the ICU, uremia, bacterial infections, and of course all of these myocarditis, pericarditis, pericardial tamponade, all always think that if it is a woman, young female with joint pains, then always think about rheumatological diseases in a rheumatological is a cause. Rheumatological disease, tuberculosis, uremia, trauma, then your malignancy. These are the common, 5, 6 diseases which are associated with this pericarditis, myocarditis thing. Myocarditis obviously has got a viral and those bacterial infections as well, and alcohol and chemotherapy drugs. So lots of causes, but yeah, it's not possible to remember everything in the exam. So just try to correlate what you see in the ICU because that will be thing that will ask in EDIC one. They will be very much clinical exam, not mugging up thing. Acute cardiac tamponade, the most important thing is this: hypotension, narrow pulse pressure, tachycardia, heart sounds are often muted or classically muffled. JVP is markedly elevated JVP, and dyspnea, chest pain, pericardial effusion can be present in patient cardiogenic shock, full extremities, cyanosis, decreased output. I think we all know this presentation. This is the Beck's triad, JVP raised, hypotension, full clammy extremities. Along with that, there can be tachycardia, tachypnea, dyspnea, and muffled heart sounds. If it is subacute cardiac tamponade, then the presentation will be less dramatic, but patients will need to evaluate whether it is increasing or not, because if it is increasing, then you have to make sure that we do regular follow-up echocardiography and regularly monitor the patient, at least in a monitored bed. Another classical feature is pulsus paradoxus, where the inspiratory reduction systolic blood pressure will be more than 10 millimeter of mercury. Sorry. So the cutoff is 10. Inspiratory reduction of systolic blood pressure and Kussmaul's elevation in JVP during inspiration during tamponade. So these are the two named signs, and by now you must have understood that EDIC part 1 are very fond of the named signs. Pulsus paradoxus, Kussmaul's sign. They will not tell about the Kussmaul or the pulsus paradox. Okay, they will just give you the picture, or they will tell that they will be elevated during inspiration, because JVP should be decreasing inspiration, right? But it's the reverse. So that way you have to understand that yes, it can be a case of cardiac tamponade. The typical raised JVP picture is attenuation of the Y descent. These are all MCQs. So this is what pulsus paradoxus is. Here you see in the first picture, this is very early stage of cardiac tamponade. So right atrial pressure is mildly elevated. So there is no paradoxus. But in this one, right side, as tamponade progresses, the pulse pressure significantly decreases, and that causes the pulsus paradoxus. Clearly, there is a pulsus paradoxus, right? Yeah, I think everybody can understand. And as you can see here, the Y descent is present. Here, there is no Y descent, but the X descent will be very prominent. You see, the X descent is very much prominent. So if this is X, this is A, right? This is X descent. If this is V, there is no Y at all. Whereas here, there is clearly a Y. So that's the difference. There will be attenuation of the Y descent, preservation of the X descent. Remember JVP, remember cardiac tamponade is this constrictive pericarditis, restrictive pericarditis will be absence of both X and Y descent. That's the difference. Echocardiography wise, yes, here is obviously the effusion. Here again the effusion. So basically in these, so the echo findings are pretty classical. You just have to mark the border of the heart, because many times in the stress of the exam, what happens? We think that this is the, we forget which is the chamber. So this is the chamber, okay, and this is the second chamber. What are these chambers? These are the right atrium and right ventricles, RA and the RV and the RA. Sorry, and this is the pericardial effusion. So there should be no confusion regarding this. This is again the pericardial effusion. You have to diagnose these things in the exam. This is a high level stuff in on as an EDIC part one. But if you do a pulse wave Doppler through the pericardial, through the, through the mitral valve, then this is the A by E which you're seeing, and as you can see, bit to bit there is a good variation. That is because of the pulses paradoxus. Exaggerated respiratory cycles in mitral and tricuspid valve surrogate for pulses paradoxus. This is also the same thing. This is the same thing. This should not be asked in the exam. This I've just, this we don't need for EDIC one. I just wanted to show you this thing. It's interesting to learn about new things, right? Because even I did not know that you can do this thing in cardiac tamponade. Because in ICU cardiac tamponade, you either monitor the patient or you directly go for pericardiocentesis. You usually don't do a pulsar Doppler through the mitral valve. Yeah. So diastolic RV collapse, it gives us severity is based on the duration of the collapse. It's highly specific. So yeah, so here as you can see, it is a pericardial effusion, and there is a diastolic RV collapse, right? Yeah, you can see this is the part which is collapsing. This is the LV. This is the RV. It's collapsing. Yeah, I mean, if you've gone through this thing, then you can. I should just erase it. So again, Eric, one question: what is the earliest sign of this? This is systolic RA collapse is the earliest sign. Okay, it is not a classical sign, which is the RV diastolic collapse, but the earliest echo finding is your systolic RA collapse, which is being collapsed. So don't forget the earliest if they mention, then it is a systolic RA collapse. Otherwise, everything else is the diastolic RV collapse. Obviously, if this pericardial effusion and cardiac tamponade are all causes of obstructive shock, so the IVC, so the blood will not be able to enter the heart, so the IVC will be dilated. It will be plethoric with no respiratory variations. Obviously, treatment is urgent pericardiocentesis, temporary barriers. Yes, blood fluids can be given, but the treatment is urgent pericardiocentesis. If the patient is hemodynamically stable, then monitor with serial echocardiography. Surgical drainage, if case it is a case of malignancy, which can be done in a planned basis. We usually do not go for this pericardial effusion score, because pericardial effusion in an ICU setup needs to be drained immediately. But yeah, there is a score. Just remember that it is based upon etiology, clinical presentation, and the imaging values. If the score is more than 6, go for the urgent pericardiocentesis. If it is less than 6, it can wait. Pericardiocentesis can be postponed. You can monitor with the routine ECG, with daily echoes. So the cutoff is 6. And the 3 steps are the etiology, it is the cause of the disease, the clinical features, and the echo findings. Mostly the imaging means echo findings only here. Coming to the last part, what is constrictive pericarditis? Constrictive pericarditis is, although there is an inelastic thickened pericardium which restricts the cardiac filling. It can happen following viral pericarditis, post surgery, post radiation. There can be again be that Kussmaul sign, that is elevated JVP inspiration, deep steep Y descent. There can be an hepatomegaly and features of right heart failure, effusion, ascites, anasarca. There is a volume overload. So this is the one. There is this band. That is the band which you can see. That is the constrictive pericarditis. You see, there is a band here, right? That is a constrictive pericarditis. Again, the band here. So the wall is thickened basically. So why do we need to know about this? You do have this because it's basically because concentric pericarditis cardiomyopathy, unless they're presenting with shock, they are not ICU cases as such. But restrictive cardiomyopathy can be incidentally detected also, especially in patients with this acute exacerbation of lung disease. They can have this. So Kussmaul sign again will be present, and again the Kussmaul sign will be present. The Kussmaul sign is present in pericardial effusion, constitutive pericarditis, restrictive cardiomyopathy. In pericardial effusion, X descent is steep, Y descent is not there. In constitutive pericarditis, Y descent is very much prominent. So these you need to very well mention. Treatment is just like before: NSAIDs, steroids, treatment of other associated disease, heart failure, chemotherapy, or constitutive pericarditis. So mainstay of treatment of chronic permanent constriction is pericardiectomy. That is a chronic disease. If there is a pericardial effusion, then basically this is very important. Volume of fluid based classification. Less than 50 ml is very unlikely that it will cause any symptoms. 50 to 100 ml is very unlikely. More than 500 ml, definitely. Anything more than 100 ml can cause tamponade. So be very careful. If it is less than a month, it is acute. If it is more than 3 months, it is chronic. If you are tapping it and if it comes to be hemorrhagic, it can be infections or malignancy. If it is serous, it can be chronic heart failure, chronic renal failure. It can be throughout the heart or it can be loculated. So these are all theoretical questions, but the important thing is this size based upon the volume and also the acute and chronic differentiations and the causes, obviously. Management is as we have discussed till now. If it is acute, then you have to remove the fluids. Otherwise, we can just monitor the patients. If there is a chronic constitutive pericarditis associated, then we can go for a pericardiectomy. So we come to the end of this pericarditis and myocarditis. A small 15 minutes part is left. Let me see how many are there. Okay, so there are 1, 2, 3, 4, 5, 6, 7, 8. So there are 8 people. I think I shall just go ahead and finish it off because the last part, as we have, in a bit of a suspense, but the last part is basically nothing but a VA. Because I thought that we are discussing about acute coronary care, and nowadays, in acute coronary care, nothing is complete without the concept of VA ECMO. I also wanted to do IABP, but IABP I think there is a third plus also in acute coronary care, if I'm not mistaken. So I think I should include the IABP in that part, and I should also include the right heart failure IABP and a few MCQs in that part. Then I think we shall, apart from the arrhythmias, we shall be covering most of the cardiology part. Anyway, so this is not about ECMO. ECMO, I think it's a separate class. This is just what is specific for VA ECMO. So VA ECMO, based upon cannulation, it can be a peripheral VA ECMO, which is a classical VA ECMO, where we go for a femoral artery cannulation and a IGV cannulation. So veno-arterial ECMO, or we can go for a femoral VA ECMO also. The second one is a central VA ECMO, which is usually done in a cardiopulmonary bypass. So the heart is opened up, and the thorax is opened up, and the ECMO cannulas are directly placed in the cardiac chambers or in the great vessels. So that is the domain of the CTVS surgeons. The third one is the peripheral VA ECMO, but not to the femoral artery. So that is coming up. So that is the one where we are using the axillary artery or the subclavian artery. So that is called a sport configuration. Okay. This is a very nice article actually. I shall give you the link to, I think, Fatima or somebody, and they can share it in your group. VA ECMO on VA ECMO. Anyway, so 5 cardinal considerations are how to select the patients. What are the indications? What are the contraindications? Indications, I think you all know: cardiogenic shock, refractory myocarditis, refractory heart failure, refractory ventricular fibrillation, these things. And what are the contraindication? No absolute contraindication, but you have to select the patients. Like patient multi-organ system failure, CNS bleeding, severe coagulopathy, ECP at unknown downtime, irreversible CNS dysfunctions, aged patients more than 70 75 years. It's non-ethical to go for a VECMO in those patients, because VECMO means the patient will have a chance to recovery, right? These patients are unlikely to recover because of the other diseases and other than the heart or the lungs. So it's unlikely that VECMO will help there. That's why they are the contraindications. Cannulation strategy I have told. In There are three things: cannulation strategy, LV distension of venting, and distal limb ischemia perfusion. I shall discuss all the three in details in the subsequent slides. So the three types of cannulation I have already discussed, but there is a risk for north-south syndrome if you're going for a femoral artery, femoral venous, or femoral artery IJV, or a upper venous ECMO. That is why the concept of this axillary artery or the subclavian artery ECMO has come up. LV distension and venting strategy, what happens is that although you are distending, or that it basically ECMO basically increases the afterload. So there is always a chance of LV distension because you are giving total rest to the heart. More the ECMO blood flow, pump blood flow, more the chance of LV distension. But if you decrease the LV pump flow to a point where the chance of distension is low, that will just there will be no point in giving the VECMO to the patient. So if you are giving a VECMO at a flow rate of something like 4 to 5 liters, you are getting the LV distension. There are 8 ways how to reduce LV distension. We shall discuss that. And finally, distal limb ischemia, because we are cannulating the femoral artery, so there is always a more chance of thrombosis in ischemia. Although we are using heparin mostly, but how to get air from the ischemia? We basically have to bypass the blood, either a peripheral 8 French dilator, or a distal posterior tibial artery, or a dorsalis pedis artery bypass. You know, thing. So this is the one. You see, this is the cannula, main cannula, and this is the bypass. So this is the common femoral artery bypass. So this is the proximal. You can also do it in this posterolateral or the distal, or the posterolateral or the dorsalis pedis. These will be called a distal parts, distal perfusion. Okay. So moving on. So you've done these things, you've taken care of these north-south syndromes and the ventings and the distal perfusions. So what is your exit strategy? Exit strategy can be either a bridge to recovery or a bridge to destination. Bridge to recovery means just like a myocarditis thing. Myocarditis generally resolves after 7 to 10 days, 14 days. So if you can just consider the VECMO the first 5 to 7 days and give some rest to the heart, the patient may recover. Otherwise, a bridge to transplant. Suppose the patient is a candidate for cardiac transplant and that donor heart is not available. So till that time, you can do it. Or a bridge to destination. So suppose you have put the patient for ECMO and the LVAD or the heart transfer doesn't happen in your center. So you can transfer the patient. Air transfer with ECMO is a completely different and a super specialized thing. We shall not discuss that here. But this is the exit strategy. Any discussion on ECMO, exit strategy is very important. And how will you get out of the ECMO? So what are the cannulations? Venous cannula and arterial cannula. Venous cannula size is typically 19 to 25 French. We are usually using 19 French or 21 French. And arterial cannula is again similar only. Something like 22 or 24 French we are using. So we have discussed about the pulmonary distension, edema and LV distension. So how to diagnose them? Very easy. LV distension occurs because the aortic valve does not open. So we can have a look at the arterial pulse pressure tracing and see whether the diacritic notch is there or not, because that is the site for the aortic valve opening. We can do an echocardiography and we can do an M-mode to the aortic valve to check for the aortic valve opening. We can also do a right radial artery, this arterial line, and see how about the oxygenation status. And the fourth is the simplest way to diagnose pulmonary edema by chest X-ray. But the gold standard remains the pulmonary artery catheter, which if you are putting on a VA ECMO, it must be a cardiac center. There, the role of pulmonary catheter is still there. It has made a comeback. Post Pacman trial, the pulmonary catheter went out of the ICU, but now it is making a comeback, especially in these complicated cardiac cases, complicated cardiogenic shock. In fact, the ACA recommendation has always been there to use the pulmonary catheter in case of complicated cardiogenic shock. So that is how the ECMO centers, our centers are making use of the pulmonary catheter. So not much different from a, from an arterial line or a central line. So now you have diagnosed that yes, there is some LV vent, LV dilatation, and you need to vent the LV. So how to go about it? We can modify the anatros vasodilators. We can put in IABP, but those are unlikely to do much of an help. The main treatment is for a surgical LV vent or a percutaneous LV vent. So these can go for a direct LV venting. Otherwise, we can also go for a impeller device, or we can go for an off-pump central VA ECMO. That is the cardiac VA. That is a surgical VA ECMO. So remember these things: surgical LV vent, percutaneous LV vent, impeller, or a central VA ECMO. It is a favorite topic for EDIC Part 2. But EDIC Part 1 also, impeller and ECMO, they are asking now. And any day they will ask about the LV venting also. Because VA ECMO, they are gradually improving the standard of the exam. So VA ECMO is being used in many centers in India and all over the world. So they will ask about VA ECMO, about the Harlequin syndrome, about the LV venting, about how to preserve the distal perfusion. Just one line you need to know. But how to diagnose? Yes, I shall look at the arterial tracing, I shall do an echo, I shall do a chest x-ray, and I shall also put a pulmonary catheter to look at the pulmonary capillary wedge pressure, which is a gold standard. And I shall vent the patient. I shall do a surgical venting, I can do a percutaneous venting, I can use an impeller, I can use a central acting this VECMO, or I can do a balloon septostomy. So this is Harlequin syndrome. What is Harlequin syndrome? Harlequin syndrome is north-south syndrome. I hope you guys know something about ECMO because I just started the ECMO without doing anything else. If you want, I can take a class on ECMO also later on in June or July. But this I just wanted to only on VA ECMO. If you do not have not read ECMO and not doing ECMO, it will be a bit difficult. I'm sorry, but today there was no time to go in depth about ECMO. I shall definitely take a class on ECMO if the the if the routine the if they allow me to. But yeah, today we shall discuss about only these three complications of VA ECMO. So one thing we will discuss. Second is Harlequin syndrome. What is Harlequin syndrome? Harlequin syndrome is basically when your heart has recovered, then the heart is trying to pump the blood, but your lungs are not recovered yet. So your lungs is not oxygenating the blood. So there is a point where the deoxygenated blood and oxygenated blood is meeting. That is the watershed area. So now the watershed area distal to the aortic arch, then the whole of the upper body is getting the deoxygenated blood, right? This deoxygenated blood through the innominate artery and the subclavian artery and the common carotid. So this part is becoming blue. The distal part is becoming red. Yeah. So this is what is Harlequin. Remember the name. It is called North Pole South Pole syndrome, Harlequin syndrome, or the red blue syndrome. And we can diagnose it with radial artery pressure waveform. If it is narrow pulse pressure, then the watershed area is in the aortic root. So this thing will happen. If it is a wide pulse pressure area, watershed area distal to the innominate artery. If the watershed is to the innominate artery, then the whole body will become blue. Okay, that is cyanosis will happen. So narrow is Harlequin. So for Harlequin, the narrow pulse pressure is required. If it is wide pulse pressure, then it is distal to the innominate artery. So the underlying pathophysiology basically a bad lungs. So you have to treat the lungs condition. We can increase the ventilator support. We can increase the PEEP, or we can go for a VAV ECMO. So you can use a venous cannulation and extra venous cannulation. The configuration is splitting the arterial outflow with a Y connector to deliver well oxygenated blood into the venous system. So basically, the venous system is giving the deoxygenated blood. So basically, from arterial, another connection to the venous flow to divert the oxygenated blood there. That is called a VAV ECMO. So treat the lungs, increase the PEEP, and go for a VAV ECMO. The third complication is how to maintain a perfusion of the cannulated leg. There are two ways. First is a 8 French vascular introducer placed distal to the arterial cannula, that is proximal part. because you have cannulated the femoral artery. So just distal to it. So still the proximal part, you are proceeding the 6th phase or 8th phase introducer. And the second part is distal perfusion in the posterior tibial artery or the dorsal artery pelvis. So VECMO, you have discussed about the cannula, you have discussed about the Harlequin syndrome, how to maintain a distal perfusion, and how to vent the LV. And now, what are the alternatives to VECMO? These are very much coming up, and LA femoral artery bypass is one alternative, but requires transseptal puncture and later a cardiac surgery to repair the puncture once the patient recovers. The second is a percutaneous transaortic microaxial flow pump, which is coming up in all the the global centers for ECMO. Just the last part is also left. I know you guys are tired, uh, but I shall just get up with it. Just the winning from the ECMO, because that is also very important. Just give me a minute. Yeah, sorry. So winning from the ECMO. So how to do that? We need to check for these prerequisites. Is the etiology of the cardiac failure solved? Is the patient able to maintain on an ECMO flow rate of 2 liters per minute? Is the pulsatile arterial waveform, that is the cardiac function there for at least 24 hours? Is the map more than 16 absence of hydroanotropes? And whether lung function is not severely impaired. So the heart and lung should have improved. The map should be more than 60. Inotrope should not be too high. There should be pulsatile waveform of more than 24 hours. And the ECMO flow should be around 2 liters, and the patient should be maintaining. So with these 6 to 7 criteria, we should arrange for a team. We should do an echocardiography. We should arrange for a winning pro forma, and we should go ahead. What to measure on the echocardiograph? Aortic VTI, mitral annulus, ejection fraction, and TAPSE. TAPSE for the right heart, ejection fraction, aortic VTI for the left heart. Next, after preparing the team in echocardiography, we decrease the ECMO flow by 0.5 liters per minute to 1 to 1.5 liters per minute every 5 minutes, and see whether the patient maintaining or not. So what do we see? We see hemodynamic parameters, echocardiographic parameters, clinical parameters. Hemodynamic parameters, you see the map, heart rate, CVP, saturation. There should not be any significant deterioration in the hemodynamics. And the cardiac function, we should regularly monitor echocardiography. There should not be any deterioration. Aortic filtration should be more than 10. The ejection fraction should at least more than 25%. Mitral annulus, this tissue plus study A should be more than 6 centimeter per second. And the patient should be like well oriented, there should be no clinical deterioration, etc. If all these things are okay, then it's okay. If not, then immediately the ECMO circuit should go back to whatever was the pre-winning setup. And the patient and hemodynamic should be closely monitored whether it is recovering or not. And no winning try for next 48 hours. We should observe, we should continuously see for any sepsis and respiratory dysfunction, any chest x-ray and repeat cultures, and echoes, those type of things. So this was about VECMO winning. Just wanted to do this today. Today's class is over from my point of view. I don't know what link you are asking, but yeah,
The
if you
ECMO,
have any
the
questions, you
sorry.
can ask me.
Hello,
Okay,
can I
you want to
talk?
make more link here? Yeah, yeah, I can hear you. I'm just trying to find out the link.
And just
So
only the
this is
link.
the trial. Yeah, I mean, how to upload this thing? I have actually have a document. I shall just share the link with the with the coordinator, and then think that person will share it with you in your group. I don't think I can upload the PDF to you, or can I? Yeah, I think that will be better if I share. I shall definitely share it with the coordinator of First Academy. I hope you enjoyed our class today. The VECMO part is something which I really like, so I included it. I think it's late. It's 9:35, 9:40 p.m. actually out here. So yeah, if there is a question, you can just share it with the coordinator, and they can ask me, and I shall share you links or any study materials if you want on cardiology or cardiomyopathy or any EDIC advice. and we shall see you in the next class. I am supposed to take a few more classes, I think, in June or something like that. So good night.
Thank you, sir.